bleeding or coagulation disorders, pediatric patients, cholesterol diverticulum, urinary diversion, renal transplant, anomalous kidneys like pelvic kidney or horseshoe kidney, and chronic kidney disease. If you had an option of ureteroscopy, you might prefer that much more than other options. Now, there are some softer indications where it's preferable, but you could do other modalities of treatment as well. So that is things like encrusted stent, lower pole stone, bilateral stones, recurrent UTI, elderly patients, patients with solitary kidneys, large stones and cystine stones. You can argue on whether a PCNL is better, but actually in softer indication, ureteroscopy could be preferred as well. So this is the extension of the standard ureteroscopy that we have talked about. So we need some tools for that, and that is your access sheath, laser with the new parameters, so you can have pulse laser, Moses laser, thulium laser, and all of that can help use and break the stone in different ways. Disposable scopes, of course, make it a little bit easier and in challenging cases because you're not worried about breaking the scope. Training is absolutely the key, and cost and whether you can discharge the patient the same day and so on becomes also important. So I'm going to share with you the one of the keys, which is the role of dusting and pop dusting. So I use this technique. We all know what dusting is, where we, start with low power and high frequency, but we have used it for large stones. So 50 patients were treated this way. We start with dusting and then go on to pop dusting. And the mean diameter was 21 millimeters, so reasonably large stones, and initial and final stone free rate. So the initial stone free rate for even large stones was 93%. And the complication, we only had one who had urosepsis. So you can see that dusting and pop dusting is actually quite a good technique for large stones. And maybe it will be a new benchmark for bilateral, multiple, or large stones. So I'm going to show you a little video. I hope it will play nicely, which shows pop dusting. And of course, we have used it for pediatric patients as well, although it's a small series. So you can see when you dust the stone, sometimes you can just keep dusting. You don't have to change it, especially if it's a soft stone. So you start dusting and you keep dusting. But sometimes after you've dusted the outer core, outer layer, the inner core is a little bit hard and dusting itself is not enough, or you might spend a long time. Then what you do is increase the setting from low power, let's say zero point 0.4 to zero point 0.6 or zero point 0.7 or zero point 0.8. And as you can see, you change it to what we call pop dusting setting. So 0.6, 0.7, 0.8 joule energy and 30 to 50 hertz. And then you can see it really increases, and the stones come to you like a washing machine setting. And at the end, all you remain is with some very tiny particles and some stone dust. So for me, even for large stones in a single setting, you can treat big stones this way. Otherwise, it may not always be possible, and you might have had to bring them back for a second procedure. So at the end, you can see what remains is just some little stone dust. So this is very important for me now. So going on to access sheath. So as I said, I use access sheath quite a lot. And I tend to use it for all kinds of renal stones. And we looked at a 7-year period of our own data. We had 203 where we used access sheath and 135 where we did not use access sheath. If you looked at the stone size, for large stones, if I could, I always prefer to use an access sheath for a variety of reasons. It decreases the internal pressure, visibility, irrigation. It helps with everything. Smaller stones where I couldn't use, when I say small, they're still large, but smaller than 17 millimeters. These were 11 millimeters roughly. The stone free rate was not bad, 88% and 94%. So slightly higher for smaller stones as you would expect. Complication rates mainly down to stent pain, sepsis in both groups, but not significantly different. So for me, this is an important tool, especially when you do an extended role of ureteroscopy in difficult patients. This comes in quite handy. Training, I mentioned, is very important. So I was a part of the European training group through all EAU sections, and we looked at how to standardize the endo-urology training. Then we did the validation, and then we did, it is now broadened horizon and it is being used worldwide. And I'd be quite happy to come down to the Middle East and do some training sessions with these. So when we look at this, Initially, we had the task list. This is how every endourologist should be trained. Flexible cystoscopy, rigid cystoscopy, and wire placement, safety wire, semi-rigid ureteroscopy, working guide wire, an access sheath if you can, and flexible ureteroscopy. And what I do in my practice every single time is this: place a safety wire, always. Then do a semi-rigid ureteroscopy over a second wire, always. Leave both wires in place. After that, if you can, if it's necessary, and if you can safely put an access sheet, because the semi-rigid ureteroscopy has passively stretched the ureter, you know if an access sheet is going to go, and if so, what size. Then use an access sheet and then do a flexible ureteroscopy. So every time I'll do it this way. So training, as you can see, is also very important. Let's talk about the pelvic ileal anatomy and the role it has for low pole stones. So we know that ureteroscopy it can be done, but where is the limit? What is the pelvic ileal anatomy that obscures it? So we looked at our data, and stone-free rate for 108 patients was 94%. But this is the key: if the infundibulopelvic angle was less than 30 degrees, and if the stones were very large, there was a higher risk of failure. And that was also seen in other studies. So we also looked at a review of literature, and similar to our study, the infundibular length was not that important, neither was the width, but it was the infundibular pelvic angle. Now, if you look at this slide here on the left, the blue bar is where all the unsuccessful procedures were, and that's the infundibular pelvic angle less than 30 degrees. So in these cases, you might want to do a PCNL or a mini PCNL. But in all other cases, as the review shows, you can safely do ureteroscopy. Now, moving on, what about chronic kidney disease? So we all know that chronic kidney disease can be a real problem because stone patients have recurrence and it can affect the kidney function. We looked at 277 patients from our series with CKD 2, 3, 4, and 5. So not CKD 1, but anything above 2. Uh, Again, stone-free rate was good, complications rate was not very high. And when we look at complications rates, mainly it was Clavian 1 or 2. Very few had Clavian 4, which was down to urosepsis, which you always expect in a large series. And ureteroscopy was seen to be safe and effective in CKD patients, and most were discharged the same day. And for majority of patients with both ureteral and renal stones, the renal function either stayed the same or improved in 6 months. So again, you can safely do ureteroscopy in patients with CKD. We also did a literature review recently where we looked at 28 articles, 7 of which had ureteroscopy. And this was the conclusion: if you have a pre-operative poor renal function or patients with diabetes and hypertension, then you have to worry about the renal function. Otherwise, it is really safe in all of the patients. Now, let's talk about cholesterol diverticulum, because this is a real problem. And a lot of times people use ureteroscopy, and this blue spritz technique has been described where you put the flexible scope, a ureteroscope, and then you put some methylene blue with some contrast, wash it. Methylene blue is taken up, as you can see, in the respective calyceal diverticula, and then you can open it with a laser. It's sometimes not possible to do it, and then you have to do a PCNL. But what if you had a combination? So here we see a video where you see the CT scan. It was in the calyceal diverticulum. It was not easy to do a retrograde ureteroscopy because of the angle. So we did a PCN. We put a wire down, and then I followed it retrogradely with the uh, laser. So the PCN and the wire guided the ureteroscope. Didn't need to do a full PCNL because there wasn't enough space. So this is another trick you can use for calyceal diverticula, a combination of a PCN guided wire down, and then you can open it with a laser. And once you've opened it with a laser, then it is much easier to do it from below. And at the end, you can remove the wire and you can simply place uh, a stent going in the diverticula itself. So this is a very handy trick. Rather than doing a standard ureteroscopy because it may not work, or doing a PCNL, which might be a big deal, you do a combination. The principles of Isers. and then you can treat the stone this way. What about patients with bleeding diathesis, anticoagulation, or antiplatelet agent? We looked at 8 studies. The stone-free rate was similar in both patients with and without bleeding diathesis. But when we look at the forest plot, and this is the key, more patients, as you would expect, in the anticoagulated group had bleeding complications, which means that if you have to treat these patients, don't just do a ureteroscopy because it can be done. You have to make it patient-centered approach. And if you can correct it, try and correct it. If it can't be possible to correct it or stop the anticoagulation, counsel the patient that the bleeding risk is slightly high than otherwise. Similarly, with retrograde ureteroscopy and urinary diversion, I think the key here is to have some tips and tricks up your sleeve. So have a flexible cystoscope handy that you can use to find the ostium of the ureteric, where you have anastomosis is there. Flexible ureteroscope, super stiff wire, access sheet sometimes can be helpful. Then avoid things like too much manipulation because it can cause hematuria or perforation. And the challenges are from anastomotic strictures, or if the urinary tract is very tortuous, then it can be difficult. And in these cases, always be prepared to have a combined antegrade approach. So although you are going retrogradely, you must be aware of these things, you must have the tools, but be prepared to come antegradely if you need to. In obese and morbidly obese patients, if you ask me, ureteroscopy is probably preferable because PCNL is not always easy. Lithotripsy has a high failure rate. And we looked at the mean BMI of these patients in 15 studies was 40.5. Stones were reasonably large, up to 14 millimeters. Stone-free rate was a little bit low than what you would expect, but sometimes that can happen with large stones anyway. But this is the key. The complications rates, the overall complication was 9.3%. But when you compare the morbidly obese patients, the complications rates was almost twice as that of obese patients. So you have to counsel and warn the patients accordingly. Although these were not high Clavian complications, but again, they need to understand that the complications rates are higher in morbidly obese patients. Talking about retrograde piecemeal removal of stents. So sometimes stent incrustations can be so bad that you have to do a PCNL. But ureteroscopy can be quite handy. And here I'm going to show you a particular case where the whole stent was completely encased. You can see like a hose pipe in the ureter. The whole stent is encased and you couldn't do anything. So sometimes in these cases, ureteroscopy, as opposed to doing a PCNL, which remains another possibility, ureteroscopy allows you to go retrogradely, and then you keep cutting the stent bit by bit, step by step, keep releasing it till you can release the whole stent and remove it. So again, in cases of extreme incrustations or where the whole stent is encased, this is a good trick to do as opposed to doing a PCNL, which can be invasive. And some of these cases, when PCNL is difficult, and very rarely people do open surgery. So I think ureteroscopy will come in handy even in these cases, which is extreme cases, but nevertheless, we all know that forgotten stents and encrusted stents can happen, and it can be a real problem. The important key thing here is to make sure you get a good angle when you're cutting the stent. If you don't get a good angle, it's difficult, and you have to cut it in stages, because if you try and cut it once, the whole stent may not come out as you want. So as you can see, bit by bit, you make progress and you clear the stone around the stent, and then you remove the stent. And this can be tedious, but sometimes this is the only way to do it. And I think these are some of the extremely challenging cases where you really need to maneuver, to use a lot of patience, any tool. So here I'm using a 3-prong grasper, standard, basket, and grasper wasn't working. And you keep going, keep cutting till the end, till you can get the stent. And here you can see the 3-prong grasper in the end. We will be able to get it out and then use an engage to remove it completely. And then get the incrustations. And then you have to go and, of course, treat the stone. People have asked me, what did you do after? Well, you treat the stone, but because the whole ureter, you can see that there is no perforation, but the whole ureter looks really rough, as you would expect. So I did leave a very temporary stent on a string for 3 days after this one. So again, ureteroscopy can be very valuable in these cases. And this is how the stent looked at the end. In anomalous kidneys, again, horseshoe kidney, ectopic kidney, flexible ureteroscopy, as you can see, has got a big role. So make sure you've got it handy if you're going to treat these patients. The stone-free rate is not great, but then it is not great irrespective of treatment. I think PCNL gives you a slightly better stone-free rate, but then higher complication rate as well. The complications rates were slightly higher, but most of them were Clavian 1 or 2, as opposed to PCNL, where the complication rates are higher Clavian grade. When we talk about solitary kidney, we looked at 27 articles, of which 9 had ureteroscopy in this. And overall, there were 792 patients that had ureteroscopy. The complication rates, again, was slightly higher than what you would expect, 15%, but most of them are Cleveland 1 and 2 related to fever or UTI. Transient rise in creatinine was seen in 21 patients. So I think in these patients, if you're worried, you have to monitor the renal function at least postoperatively for a short length of time. But PCNL was good for large stones and ureteroscopy and lithotripsy for slightly smaller stones, but good stone-free rate was obtained irrespective of treatment. Ureteroscopy for renal transplant is really something which is catching up, and it is something that has to be done in a big center. So, this is a review looking at pre and post-transplant ureteroscopy for lithiasis. And really the key is that you have to have a good endo-urology team and a transplant team. Bench ureteroscopy can be helpful sometimes, so that where the patient is, the kidney is taken out of the donor and before it's planted to the recipient, you can remove the stone at this stage. And again, the key is to have all tips and tricks. So you need different type of wire, scopes, accessories, because this is a precious kidney for both the donor and the recipient, and you want to get it right. But I think, again, you need good experience, good team, and this should be done really where there is a transplant team as well. Cystine stones can be a real pain, and the key to this treatment of this is, yes, you can use a PCNL, but you can also use ureteroscopy. They have a high surgical procedure rate per patient per year, and usually these patients will have, if you see, in a mean follow-up of 6 years, they have between 2 and 10 procedures per patient. So use of ureteroscopy in these patients is increasing, and I think it is something that we'll see more of. Elderly patients, we have looked at our series of 110 patients. There's a slightly high, again, complication rate in the elderly when we compare different series, but it is really feasible. And I would say most of the patients can go home the same day as opposed to PCNL. So for me, even in elderly, this is quite a good treatment of choice. Pediatric population, we have got very good experience of pediatric population, including using access sheet. Here, I would just warn that use the smallest sheet possible. 9.5, 11.5 is my preferred if I do use it. Long-term outcomes, there is no problem using access sheet if you do it carefully. And really, we have looked at 100 patients in our center. 81 patients had 102 procedures, and the stone-free rate was really good. So the overall stone-free rate was 99%. Of course, some patients needed more than one procedure, as you can see, and there was only 3 complications in this. The 1 went to ICU and 2 were just UTIs. So pediatric patients can very safely have ureteroscopy. There's only one warning I'll give you, which is this slide here. Under 6 years of age, be very careful. There's a high failure rate, and the complication rate is almost 4 times as much. So be very careful if you're doing pediatric ureteroscopy. I always team up with a pediatric urologist. We do it together, but have a team and make sure you're much more careful under 6, or pass it on to somebody who does it more regularly. Now, when we look at other indications of stone disease, sometimes stones can be hidden within a mucosa, and this you won't know if you're doing a PCNL or if you're doing a lithotripsy. And this is very handy when it comes to ureteroscopy. Here you see the mucosa is hiding the stone, and it's only a matter of time before the stone is going to drop. So in some of these cases, as opposed to a diverticulum, you can very easily open the mucosal layer with a laser, and then it's a standard stone procedure. You can break the stone, And when you do it, the patient stays treated. If you do lithotripsy for some of these stones, it's never going to work, because even if the stone gets broken, it is not going to probably pass out of this mucosal film. So you can see that in some of these cases, it's very handy too. In pregnancy, the use is increasing, but again, you need a multidisciplinary management. And for us, if I have a pregnant patient, I involve the obstetricians, the midwives, and the radiologist, because you're going to use ultrasound. We don't do it, so we get the radiologist. And preferentially, it should be done in a regional center. Avoid radiation and try and minimize harm to mother and baby. So my advice in pregnancy, if you don't have to do a procedure, don't do it. If you have to do it, do the minimum, maybe a stent, maybe a nephrostomy. If you have to do something and that has to be done, only then do ureteroscopy. But that is, again, not the first resort just because you can do it. Patients who have urosepsis have an emergency procedure like a nephrostomy or a stent. Here we have a group of 76 patients, a third of which were admitted to ICU and had a stent. And when you electively do a surgery, so electively, so the initial nephrostomy or stent is done, sepsis is treated. When they come for a subsequent procedure, ureteroscopy is brilliant, as you can see. Very good stone-free rate, 97%, very low complication rate as opposed to PCNL. For me, this is, again, I would always do ureteroscopy in such patients, unless the stone is really big. So worldwide, as we know, the trend of ureteroscopy is rising and lithotripsy is decreasing. PCNL is probably stable. And just to give my verdict about the expanding roles, I think our IRS is increasing and will continue to do so. It can be difficult in certain patients and circumstances, and where RIRS is especially useful compared to PCNL or compared to lithotripsy. And there are new techniques and new technology which keeps pushing the boundaries of ureteroscopy. Digital and disposable technology will change, and it is changing already. And I think one of the key elements here is, as the cost comes down, more and more people will have access and more people are going to use it. And we are united. Thank you.
Thank you very much. Hello.
Thank you very much.
Shall we discuss it with the panel?
Bhashkar, if you want, we can start the polling.
Yes.
I prepared the question as you wanted. So the first question is about the flexible ureteroscopy. So guys, you will have a question and then you will have to answer. So we'll give you like 10-15 seconds for the answer. Anyone just press on that and then we will see the results at the end.
So this is for the audience to answer.
I'll tell you my bias after the answer has come.
Yeah. It's very interesting,
Right,
actually.
so now it's about like, okay, 61, 70, 75 people. Okay, 80 even. All right. So 1, 2, 3, end. So do you see the result? Share results.
84% said that it decreases the rate of the PCNL.
Yeah, and I'll tell you, I think this is a worldwide phenomena. I mean, the only thing that is saving PCNL is the new technique, the minimally invasive PCNLs. You know, the mini PCNL has come in, the ultra mini PCNL. So those things have revived PCNL again, supine PCNL. But otherwise, for a lot of patients, if you can do a good ureteroscopy, if you are a patient, what would you prefer? And I can tell you, a lot of people would prefer ureteroscopy, I think.
Can I add something, please, if you don't mind?
Please, Tariq.
Yeah, thank you very much. So I was going to leave this to the last, but since you mentioned it, I want to, lately I do, of course, more URSs than I do PCNL, but I'm also very fond of PCNLs for big stones. And I have a few patients who have undergone both procedures.
Yeah.
So from their perspective, from a patient's perspective, I noticed that most of them prefer PCNL. Less pain, less stent time, especially if you're doing a big stone.
Yeah.
So What do you think?
Look, I think it depends on, first of all, I think for every procedure, you need to have your own data and your own outcome. And I agree with you. I think the main problem with ureteroscopy, which I haven't mentioned, is stent symptoms and the pain that comes with it. Now, these patients that you have talked about, I'm sure you're very good at the job, Tarek. They have not had a PCNL complication. Would a patient who had PCNL complication say the same thing if they had to choose it again? Because we all know that PCNL has a higher risk of major complications as well. So these are patients who are recurrent stone formers and they have been fine with both procedures, and then they can say, well, I prefer that. But as a surgeon, I'm not saying I won't do PCNL. Of course, I do PCNL. So I showed in my slide the lower pole angle. So for me, if it's a lower pole stone bigger than 1.5 centimeter, I look at the angle. If it's steep, then I would offer them a mini PCNL. If the stone is really large, so for me, probably 2.5 centimeter or more, then I'll think of a PCNL. More than 3, I would go for a PCNL as well. But I wouldn't go for all cases. And I think you have to tell the patient and counsel them accordingly. But I completely agree. Not all patients need ureteroscopy. Some of them will need PCNL. And at the end of the day, as you say, we should give them the choice as well.
I agree with you regarding that mini PSNL changed the game in comparison between the flexible ureteroscopy and the PSNL per se. The issue that I always discuss with my colleagues is that I think that urologists, not endo-urologists, are pushing the limits with the flexible ureteroscopy. They think it's an easy job. Sometimes they don't follow the basics. And ureteroscopy is not a complication-free procedure. The complication can be horrible complications with the urethral access sheath, with the urosepsis if they didn't respect the intrarenal pressure.
Yeah.
And as I said, a lot of urologists are pushing the limits, especially that now flexible ureteroscopy is available for everybody, especially with the introduction of the disposable flexible ureteroscopy. They're treating more larger and larger stones, multiple sessions. But as you said, the problem is that still mini PCNL, even in the guidelines, it didn't take its, a clear rule, which cases can you do mini PCNL with. But it's interesting, especially with the new technologies like the thulium fiber, laser fiber.
Yeah.
What's going to happen in the next few years?
To be honest, I think you're right. People are getting more aggressive just because they can treat it, and respecting the anatomy, internal pressure, completely agree. The access sheath use, I would say, a lot of people do not routinely do semi-rigid ureteroscopy. And in my view, I'm not going to say it's wrong because some of these people are very experienced. Once you're experienced, you can do what you like. But in my view, I would always do a semi-rigid ureteroscopy that gives you an idea of the anatomy, whether an access sheath is going to go in. That tells you what size of access sheet so you don't end up opening and wasting it. And semi-rigid ureteroscopy doesn't take that long. It adds maybe 2 or 3 minutes to the whole procedure. So I think the access sheet problems that people say is when they have not done a mapping of the ureter. They don't know whether an access sheet can be used. They have not passively dilated it. But I agree, people can get very aggressive with ureteroscopy, which is not right.
Another interesting thing about urologists like yourself who do a semi-rigid ureteroscopy prior to flexible or prior to the urethral access sheath is the finding of incidental stone in the ureter.
Completely, yeah, I agree. And that is one time where the retrograde might not help you because you might think it's okay, but actually there is a small, even if there is a small stone, it can cause a problem.
Can just
Can I add one more thing, please?
Dr. Abdurrahman Al-Aoun, if you have a comment, go ahead.
Yes. Now, regarding another important use of flexible ureteroscope in impacted stones. Just we need a little bit about it because the recommendation now, like upper ureteric impacted stone with antegrade flexible ureteroscopy, it's or antegrade way, it's also has a rule. Maybe you didn't mention it in the expanding rule. If you have some comments about that.
I agree. I think because it is like a PCN and then you do it. That's why I didn't mention, but I agree completely. that, it is not just retrograde ureteroscopy. When you talk about ureteroscopy, there is also a role of antegrade ureteroscopy. And you can come from above, get to the stone, and treat the stone. And even that way, it is still ureteroscopy. And you have to be open to all approaches when you're doing it, and use everything at your disposal. So, in fact, I had a video. I wasn't sure how long this will be. So I have used it for a few cases myself, and it works really well, because when you come from above, you are above the area of the edema. You can break the stone nicely, and the procedure, and you can end up with an antegrade stent and leave the nephrostomy free. So I completely agree.
We have,
Can I add one more thing, if you don't
yes,
mind?
go ahead, Tariq.
So one thing, and this is because we have almost we're full. The room is full. We have 100 participants. So
I
it's,
know, it's excellent.
the topic is. We wish that we could have more, actually.
Now we have about 50 people on YouTube.
Good.
I'm
That's
following
very
them,
good.
answer the
So
questions.
so the thing is, people are extending. You mentioned this, but I want to stress on this. People are extending the use of ureteroscopy for stones, in renal stones, but you have to know what your limit is and what your instruments are. You gave a lovely video because you're using 100-watt laser, so you're using a lovely setting for stones. I have 100-watt laser in Prince Sultan Military Medical City. I don't mind treating even 2.5, 3 centimeter stones. It wouldn't take much time when you're trying to dust. But if you're in a hospital where you have a 20-watt laser or a 30-watt laser, treating that stone might not be as easy as they think. It's going to take a lot of time, and other options might be much easier
Yeah.
if the patient is not willing to do multiple procedures, because um, some of these procedures are costly, even from a patient perspective, not only from the hospital point of view. And probably doing one PCNL is less costly than doing three, probably, URSs.
Yeah.
So I think knowing what your instruments are and what do you have is also very important in the decision making. But I agree with you. If you have a 100-watt laser, of course, it's lovely. It takes probably like 1.5 centimeter stone would probably take you 20 minutes to do.
Yeah.
That's my comment, and I would like to hear your feedback on this. The second thing is that I would like to ask a question, because lately my colleagues in pediatric urology has been showering me with pediatric stones, and I'm doing a lot of URSs in pediatrics.
Yeah.
Do you stent them before you do URS or not? If the ureter is virgin, do you stent them before doing URS or not?
So, so I'll take the first question first. So the laser setting is very important. Your machine is very important, and I completely agree. You need to know what laser you have, and if you're so my principle and the time you mentioned, I agree. So my principle, most stones I need to finish in 60 minutes, maximum 90. If there is a patient who is really anesthetic says one anesthetic only, and for whatever reason you can't do a PCNL, I might extend that 90 minutes to just over 90 minutes, because to try and finish everything in one and not bring them for a second anesthetic. So that's that. And so if you have a low powered laser, you shouldn't try and push the limit to very big stones, because you will be there for a long time. Agreed. The pediatric patients, so I have been doing it for now 10 years now. And what you realize, the internal anatomy, unless they are less than 6 years or 5 years, it's very similar to adults. The important thing there is you have to have an open mind. So you don't always need to stent them, but you need to have a 4.8, the fine, 4.5 Wolf fine rigid ureteroscope. So that is so fine. It is like a needle scope. It can go through most ureters. You need to have that, number one. Number two, I don't use a digital scope for them, because digital scope is slightly big. For me, my go-to scope, and there's a slight bias because I've always used them, is the Stodd's non-digital, the reusable Stodd's scope.
Flex X2.
Flex X2, because that goes up very nicely in most ureters. But if there is a tightness, I don't dilate them, but I do it in the same way. So semi-rigid ureteroscopy, wire. Occasionally, I use an access sheet if I think, but if I do use it, it's always the smallest one, 9.5, 11.5. And if I can get a flexi up railroad, I'll do that, break the stone. If it doesn't go, I will stent them. I would say in our hands, the stenting rate is about 20% to 25%. Most of the time, we don't pre-stent. You can go do. And the beauty is, afterwards, in pediatric, you don't have to stent as often as adults. So the post-op stent rate for me is half of what I do in adults, because the kids pass larger stone fragments or residual fragments if you have much more easily, or the stone dust. So again, once you get enough experience, you can do it, and you don't have to pre-stent in all cases.
Yeah,
But you might have to.
I have the second question that we're gonna send to the people to answer is about the type of the laser that they have. So this is the one. You can go with multiple choices. So you can choose more than one if you have more than one laser. All right. 5 more seconds. It's like 50 people answer the question from 100. Once we reach, okay, so share results.
Okay.
Is it shared clear to everyone? Can you see it?
Yeah, it's nice and clear.
So I guess a lot of people have more than one laser in the hospital, is what I'm getting. Like mine, I've got a 20 watt and a 100 watt in one hospital, and other type of lasers in other hospitals. And if you can have more than one laser, it is quite nice to have one which is a high powered laser.
Okay. So we have few questions in for the people who's in YouTube. They couldn't send it to us, so they send it here. Most of that is about the access sheet. Is how easy or how frequent you use the access sheet. And then the second question is, what's your experience in using access sheet in the transplanted ureter or using ureteroscopy in the transplanted ureter? And the third one related to the access sheet is where the level of the access sheet where is the level that you stop your access sheet, in the mid ureter and UPJ, above the UPJ.
So the first question, access sheet, how often do I use it? So I use it for a large proportion of my cases. And I'll tell you why. If it's a small stone that I think I can go and just basket and get out, or just dust, then I may not. But in a lot of cases, the type of stones I have is over 1 centimeter. And having an access sheet, if it's a hard stone, I can pull out the fragments. So you can break it into few and pull out. If it's a really large stone, you can't keep pulling out the fragments. Then you can dust it or pop dust it, but then you have a low pressure, you have a good visibility. Transplanted ureter, I would say be careful, because the ureteric ostium, the new ostium that is there, is not in the anatomical place. It is somewhere in the dome, which makes it a lot difficult to actually place the access sheet, and you might end up traumatizing that. And this is a very precious ureter, compared to the normal anatomical ureter. So if you're going to use it, be very careful. I try not to use it in transplant cases. The access to the transplant cases, if you were going to use, if you're going to use, the third question is, where do you place it? I try and place it just below the PUJ for two reasons. One, the PUJ can be quite narrow, and if you're going above, you can traumatize it. So I try and place it just below the PUJ, sometimes in the upper ureter if the proximal ureter is tight, but just below the PUJ is ideal.
Okay, one more thing for that is, when you part of using the access sheet is to decrease the pressure in the renal pelvis. So if you are putting the access sheet below the renal pelvis, you might not be able to reach that point.
That's a good point. The thing is, if it's just below the PUJ, when your scope is in, the PUJ is open by your scope. So if you are in the upper ureter or quite low down, then I agree, it doesn't transmit. But you are just below the PUJ. When it's just below and the scope is in, that opens it. So then it doesn't make a difference.
Okay. One more question is, what type of irrigation do you prefer to use? A gravity aided or mechanical pump, or a pressure regulated pump?
So this will be controversial from my side.
This is Dr. Venkat.
So I know that people use different things: Pathfinder, hand pump, foot pump. I normally have a giving set with two bags connected, one on simple gravity and one with a pressure cuff around it. And I'll tell you why. I try and use the gravity one till I get a good view. When the view goes, if there is something, then I ask them to switch. But the important thing here, which is what with experience, if the view is really good and you can see very clearly, check the pressure. Just get the scope out and see how much fluid is coming out. And most of the time, you can just
Sure.
check it immediately. And that is not something that you can teach people. It's something that comes with experience. If you think that, suddenly everything is really good, check the pressure. Sometimes when the pressure is very high, like you see in the bladder, there is some decompression, there's some bleeding because it's too high. So in either cases, check the pressure, bring the scope out and check how much fluid you're getting through. And I always try and keep it as low as possible, but I use a double giving set, one without pressure and keep using it, and one with pressure, and I swap in between as and when I need to.
Great. Any question from the panel?
Yes.
Yeah, Dr. Abdurrahman.
Regarding the new technology now, regarding the single-use ureteroscopy, I think it's widespreading now everywhere, and there is in the market maybe now about 20 less or more. So with this crisis now, COVID-19, the resources should be directed in a good way regarding the cost effectiveness. And there is a lot of driven from the company regarding this type of single use. And many study, there is a lot of debate regarding, is it cost effective in low volume center, high volume center, or is it like center specific? You can use both or some indication for single use. What's your opinion about this?
So I think you really need to be very rich to use it in every single case. Unless you break the scope very often, then you can justify it. Or if you're at a training center and have a lot of junior trainees who come, junior residents, where the scope gets broken. Otherwise, I can't afford to use it in every case. But I definitely think there is a role for it. And I'll tell you where I use it. So if I'm doing a difficult lower pool stone or stones which are larger than 2 centimeters, then I know that there is a higher risk of scope damage. That's where I'll use them. If they have had previous urosepsis or proven sepsis from before, where there is a risk of, contamination or whatever, or scope getting contaminated, then I'll use it. If there's urinary diversion, where again, the angles are difficult. So anywhere where you think anatomically the scope is under more stress, I'll use it. But for box standard case, I'm not going to use it, at least in our center, because you can't justify it. Now, when it comes to breaking, if you're breaking the scope, and that is not just down to surgeon, it could be down to how it's processed, the transit time from where it's processed, and it comes back to you. But if you're breaking your scope less than 15 times, so a scope that lasts less than 15 cases, then I think the cost justifies you having a single use. But if it's more than that, then you have to look at your center and whether you can afford it in every case. In our center, we don't. I mean, I have access to 10 flexible ureteroscopes, reusable, but I still use the single use for these indications, but not for every case.
Wonderful. May I ask one thing? Hello?
Yeah, go ahead.
So, just I would like to ask about the since we're talking about extending the use of ureteroscopy, and I just wanted to know your view about the thulium laser, and there's been a talk about it cuts the time and it gives you more fragments, and maybe you can treat more stones or bigger stones in lesser time. So I wanted to know if you have experience with the thulium laser.
Personally, I don't, because it's still not approved in Europe, so we can't use it. But I have seen and spoken to a lot of people who have used it either in patients or in the lab. I think the main problem is after a certain point, the stone size becomes a problem, because after 2.5 centimeters, you can break as much as you like. But the dust, even if it's fine dust, It's all there. The vision is obscured. So that is, and even if you can suck it out and you can, so you're against the operative time, you have to keep the time to minimum. Yes, you can go faster, but what does faster mean? You can break the stone, but the amount of dust and the visual disturbance that is created will still be there. Second thing, some people who have used it, and I've spoken to some people, and there was some concern on Twitter about ureteric stenosis. Now, I don't know whether it's down to people using a very high frequency in the ureter, which means that sometimes you can't control the laser fiber as well as you would in a smaller frequency, or is it genuinely the laser itself? Personally, I don't think it's the laser itself. It's a tool. It's how you handle the tool. Whether it will replace holmium laser completely, I don't know. I think we have to wait for more studies. At the moment, I think the jury is still out, but I do think that because of other reasons, not just clinical reasons, it's more portable, it is less expensive. And these two things will mean that there will be a shift towards thulium laser for sure. Because if you're a surgeon working in 3 hospitals and you can take it in a box and go from one to the other hospital, it sounds much more promising. And the cost is also more promising from what I gather. But it's not just the clinical need. The clinical need might take a long time to prove, but it's the portability that makes it quite user-friendly.
So the next question was, do you have a knowledge about thulium laser fiber? We have like 70 people, 66. So, and we'll end the question in 4, 3, 2, 1. Go ahead. So it's like 29, 41%. They're aware of that and they know the knowledge, and it's about 59% no.
So regarding the thulium fiber laser, you gave a very nice comments regarding that. So the comments that you gave us the thought that you don't think that it will change dramatically the guidelines regarding the treatment of the stones, because still, if you have a large stone, even if you go faster, you still have a lot of dust. You have a lot of fragments if you're doing fragmenting. And there's also a thing that a lot of people discussing regarding the high frequencies are used in the thulium fiber laser, which are the increase in the heat effect. Is it significant to cause a damage in the kidney or not?
Again, I mean, when you look at the results that people are talking, they are talking about 2000 frequency. I mean, realistically, you're not going to use, I mean, most of us are not going to use 2000 frequency. But even if the frequency goes to 400 or 500, which is what people are talking in a realistic term, remember, I mean, it is not going to go up that much. So I think with time, you will know how to control it. So let's say with holmium laser, maybe you are pressing the pedal for 30 seconds or 40 seconds at one go. With thulium fiber laser, you will know and learn to press it for 10 seconds and then give a pause and then press it for 10 seconds. So I think there are ways around it. I think we'll have to wait for more clinical data before we can make any comment on how it's going to behave. But there is a very good review article I have just written. If people who say they don't have enough knowledge about thulium fiber laser, it's going to come out in the, it's an invited article in the Turkish journal, and it's open access, so you're very welcome to share it. That talks everything that you need to know about thulium fiber laser.
It is out the last week. I actually saw it in TAU, I think.
Yes. So it is out. So it talks about
very nice.
from
It's very
basics
nice
to everything about thulium fiber laser.
Yeah, it's a very nice article.
One question, Adil, if it's possible.
Yes,
practical thing, just we need to, for the audience also, regarding the stent, we know the most common morbidity after URS is the stent.
Yeah.
So when you decide to put stent for your patient, and the second thing, the follow-up imaging. There is a lot of controversy when we will follow your patient because we are worried about silent obstruction or hydronephrosis.
And when to remove the stent. Don't forget that. Some people, they leave it for 3 days. They put the thread. Some people, they leave it for 1 week, 2 weeks. And then if you leave it for a longer time, you get incrustation. And there was question about that. But we'll hear the answer and then we'll ask the second question.
Yeah.
Okay. Thank you.
Thank you both. I mean, look, I think really, if you look at it, different countries have different way of reimbursement, right? And a lot of it is down to finance as well. Don't forget, it should be clinical, but we all know that in real world, it comes down to money as well. If the reimbursement system works in a way that you need to go and remove the stent, a lot of people have a stent put in, a proper stent. Because with a string, if you remove it, you might not get reimbursed. Now, not everyone will do it this way. So if you ask me, what do? I used to leave a lot more stent previously. I don't anymore because it's a worry. More than anything, you are worried. And gradually, data has shown that stenting rates can be lowered. The only problem is when you don't stent afterwards, more patients have renal colic or post-op colic, and they need to stay overnight. So you need to balance the two. On the one hand, you need to put less stents. On the other hand, if the patient has to go home and whatever, you need to balance. So I think for distal stones, if it's straightforward, you shouldn't put stents, or most of them don't need. For mid stones, you have to judge how the procedure was. Again, you probably don't need to. For small renal stones, if you were straightforward, you went in, a little bit of dust, you don't need to. I think if you use an access sheet or if you're treating large stones, then I have a low threshold to then leave a stent, rightly or wrongly. Now, if you leave a stent, realistically, you probably need it for short length of time because it's only the mucosal edema, the clot colic, and the little fragment that should drain out. So that means from anywhere from 3 to 7 days is probably enough. If you're worried, or if there was a perforation, or if there was an impaction, then you need to leave it for 2 weeks or longer, and then you need to leave a proper stent. But I'm sure different people have different opinion in it, and there is no right or wrong.
All right, the question that
Can I
if
ask
you're having
question, please?
incrustation, Tariq, let me just ask the question and then I'll give it to you. If you have an incrustation in that,
Yeah.
like if you leave the stent for 4 years or 5 years, you don't know, leave it, it's left there, and the patient comes with like the picture or the video you showed, incrustation, the whole stent.
Yeah.
Is there any rule for giving the patient alkalinizing medication before? Is there any rule for as well before going in, or nephrostomy tube insertion?
That's a very good question. I think the one I showed you, that I found only in the operating room. I didn't know from before that it'll be like that because the whole stent was like a hose pipe. Alkalinizing is a very interesting area. I was not a big believer in it till a few years ago. Now I am. But remember, alkalinizing will only work if you've got a uric acid type of infestation, which may not always be the case. But if it's a uric acid stone from before, if the patient has got uric acid, the pH is in that acidic range, then I think it might work very well. And I have had 2 patients where the encrusted stents were treated with sodium bicarbonate, and it worked really well. But
go ahead, continue, Doctor.
Sorry, but it will not work in all cases. And so you have to judge that by the patient and the past history of previous stone analysis. But you might, if this didn't work, so the video I showed it worked, but if let's say it didn't work and I had to cut the stent and the top went in the kidney and there was a bigger stone there, then you had to put a PCNL and do a PCNL at a later date. That would be the only option.
Okay, Dr. Tariq?
Yeah, I was, since we're talking about DG stents, I actually put a lot of DG stents, but I put more stents with thread. So I would put a thread if I can, if I think it's going to be less than a week, like 3 days, 5 days.
I'll ask the rest of the panel regarding their opinion. So go ahead, Dr. Tariq, continue, please.
I'll keep a thread. If I think that he needs longer time, then that's the time when I don't leave a thread. But I do put a lot of DG stents. My question is, if you put a DG stent and you think the DG stent is going to stay for 2 weeks and you're not going to leave a thread for him, do you give him alpha blocker and anticholinergics?
So we actually did a review on stent on strings. And the problem with strings is in 10% of cases, there is spontaneous expulsion. Now, when I say spontaneous expulsion, patient was transferred across, then somebody accidentally pulled it, the patient accidentally pulled it, and so on. So if you really needed a stent, then stent on string might put you in trouble if you really needed a stent for clinical reason. The question about alpha blocker and anticholinergics, I don't, but if a patient has had a past history of, of poor experience, or I tell them that if you get a lot of stent trouble, then let us know and we can get you prescribed an alpha blocker and or an anticholinergic. But I don't give it routinely to every patient. Yeah.
Dr. Abdurrahman Al-Aoun, what's your experience in the stents? Do you put stents for everyone?
Usually, if it's straightforward ureteroscopy without like bleeding, any complication, I will not put stent. But if I am worried, I just put a stent with a thread. I'll remove it in 5 days, seven days maximum. If I needed to keep, if there is any extravasation or there is fragment or I'm worried to come back, I will leave regular stent for like 2 weeks or 3 weeks, then come back for another session or staged ureteroscopy.
Dr. Wissam?
5 or 6, by the way.
Go ahead, Doctor.
5
Yes.
or 6, by the way.
Yeah,
Use the usual 6 French or 5 French.
I use the smallest size,
4.8.
Yeah, 4.8 sometime, or 6, but most of the time I use the smallest one.
Yeah, actually, I'm more generous in using digistents after ureteroscopy than using them in PCNL, especially in mini-perc. In mini-perc, I put a ureteric catheter that I can remove the next day. But with the flexible ureteroscope, I'm more generous in using digistents afterwards, especially with the introduction of the disposable Iseris from Coloplast. Since we introduced it in our hospital, so we can do it, in 1 minute, the resident can do it and remove a digistent after 1 week to 2 weeks. And, it's not that bothersome for the patient to have a digistent for 1 week. So I think, yes, I can sleep better at night.
Well, the patient will not sleep then if you sleep with the symptoms of.
No,
Yeah,
that
we can, so as Tariq mentioned, we have to consider also the size of the digistent. Using a smaller size like 4.8 and using a shorter digistent. I'm not a big fan of the multi-length digistents. I try to use the shortest digistent as possible. So you can reduce the symptoms, the symptoms with these parameters.
I actually measure the ureter. So this was going to be my next question. How do you choose the size of your stent? Do you measure the actual length of the ureter? Do you personally, I use the CT scan and I measure the ureter length from the PUJ down to the bladder, and I add 2 centimeters to that, and I put a digestent. So I would like to know, how do you choose the length of your digestants? I'm not fond of putting the multi-length. I actually, the shortest possible digestants to minimize the symptoms of the patient.
The same for me as well.
So I have to say measure the length. I think the main problem is when you have a big department. So we do a lot of ureteroscopies, and if you have multiple stents in the shelf, then the staff sometimes get confused and they don't know what to open. So in the pediatric theater, we have all 4.8, but in the adult theater, we have all 6, unless they need a bigger one, then they have to ask for it. And the most commonly one that we use, the most common one for the post-op is a multi-length, and I agree that that is probably not ideal, but I don't usually measure it. For females, I use a smaller length, so it could be 24, and for males at 28. But it's mainly most studies have not shown any quality of life benefit. A stent is a stent. Studies have not shown any benefit of less symptoms with the size or length. There are multiple studies done on this. But I agree. If you can, and if it's pragmatic, choose a smaller size and a smaller length. Logically, it makes sense. Or leave no stent at all, if you can.
Can I ask the people?
What about incrustation? Do you think that increasing the surface area of the digistent by using a multi-length digistent will increase the chance of incrustation?
I suspect so, but again, I think the main problem with incrustation is leaving it for a very long time. So if you take out a stent in 7 days' time, I don't think any stent, you might have In very rarely in uric acid patients or cysteine patients, you might have a little bit, but not a lot. But it's when you leave the stent for a very long time, that's when these problems begin. So the case I showed, that stent unfortunately was left for 7 months because of various reasons. The patient wasn't fit and so on. So yeah.
So
Okay.
here's the answer is about most of the people that like to use a specific size.
Right.
There are many ways of using that. As they mentioned, either they measure or there are some table for the height of the patient that you can use specific length. I usually, like you, put about a size 24 for female, or when I see a short patient, I try most of the time 28 is enough to go in most of the cases. I can't remember that I've required or needed to use multi-length in a patient because of short stent. Now I have one more question, and now we have like 5 minutes to go. So one more question is very important. Do you recommend or not recommend? Do you re-sterilize, or what do you think about re-sterilizing the reusable ureteroscope? And if they re-sterilize it, how many times do you think they will be able to use it again?
You mean reusable or single use?
No, single use.
Single use, yeah. I mean, in a lot of Western countries and in UK, we are not allowed to legally, so we don't. But I know of other colleagues elsewhere. I mean, I was talking to a few people. It's not uncommon in a lot of places because it's down to the cost. What do I think about it? I think companies don't want you to, for a variety of reasons. It might be to do with contamination. It might be to do with the way the technology is made, that you shouldn't be using it. So if you look the company line, they don't recommend it. Practically, it is about the health economics of a particular system or region or country, and that's something that people have to decide for themselves. But we don't use it here.
Dr. Adil, just one question, if possible. Regarding the lower ball stone, if it's more than 1.5 centimeter, are you favoring to do like staged ureteroscopy, or you will go for like PCNL conventional or mini PCNL? What do you think?
So I always now, after I've looked at my data, because I didn't know the angle was so important, I look at the angle. If the angle is less than 30 degrees, I would go for a mini PCNL straight away now. If the angle is not less, then I'll talk to the patient and tell them, some patients say, I want one stop, I just want a PCNL. Some people will say, I want ureteroscopy, and if you need a second one, so be it. So, but if it's definitely more than 1.5, in my mind, mini PCNL is at par or slightly ahead of URS in the lower pool. But I look at the angle, and then more than 2, I would do a mini PCNL for sure.
Okay, now let's the last question that we will share it with everyone. If you have 1.8 centimeter renal stone in, how do you treat it? We use flexible ureteroscopy as well, or mini PCNL. We'll assume that it is 1.8 renal pelvis, is not upper or lower, so we'll make it straightforward. Now, you're talking about 50 people, move. We'll give them a time. It's always difficult. So especially when we talk about choosing the proper one or proper treatment or modality, especially when you talk about governmental hospital, private hospital, are we doing that in one session? Are we doing that? In private setting, I'm telling that most of the patient like to do ureteroscopy because it's a day surgery case, and patient will go home after. Some of them they like PCNL. Yeah, some of them they like PCNL because they're worried about the stent symptoms. Some of them they like to be one session. So each has advantage and disadvantage. As long as we sit down with the patient, explain everything, the risk and benefit of each procedure, and then it's fine. And whatever procedure I feel I'm comfortable with, the infrastructure, or sorry, the instruments that we have in the hospital, if you have all range of laser, access sheet, stents, then you can go ahead and do like more complex ureteroscopy. If you have like PCNL instruments, then maybe PCNL it's much easier for you. So let's see the results of the poll. It's most of the people will go with that answer, 60% or 63% flexible ureteroscopy, about 18% as well, and about 19% mini PCNL. We finished 1 hour of our meeting, and if you, Dr. Bhashkar, if you have any comment before we conclude.
Honestly, this was incredible, very, very good. The panel was superb. You guys made it very interactive. And I can't believe 100 people joined in. I mean, I'm sure.
No, 160.
100.
So we have like 60 people on YouTube. I'm following them. I'm following the question also. So some of the questions from there also.
And to be honest, it was only in 5 days' time, because we only decided it 5 days ago. So this is great. Well done, guys. And I'm sure this is the future. Although I would like to come there sometime, you know, once this is settled. But this is the future.
You're more than welcome. We'll be happy to have you in person, and we will sit down and we can prepare cases. Dr. Abdurrahman, any comment before we conclude?
Thank you very much, Dr. Bhashkar, to join us. It's our pleasure and honor to have you tonight. In behalf of me and Saudi Urology Association and my friend, and we're looking forward to see you again.
Thank you so much. My pleasure.
Thank you very much. Yes, it was a pleasure, and thank you very much. Lovely presentation. I liked it, and wonderful discussion. Thank you very much for this organization.
Thank you, Tariq.
Dr. Wissam?
Thank you very much, Bhashkar, for joining us. A very interesting topic. I think we would have gone for 1 hour more with the discussion. It's very interesting with the panel. I'd like to thank also all the panelists, and also Dr. Saeed bin Hamri for arranging this meeting in the beginning. But it was, as I said, a great topic and very well presented, and we'd love to have you in the future.
And thanks to the audience as well. 160 is
Thank you,
great
for the audience.
at YouTube and here. So until we catch up again, take care, guys. Thank you so much.
Thank you very much, everyone. And the meeting is recorded in YouTube. You can go back to that channel and view the whole thing. Thanks again. Have a nice evening and happy Ramadan for everyone.
Happy Ramadan.
Tomorrow.
Thanks for Bosen and Coloplast for their sponsoring.
Dr. Adil?
Yes, go ahead.
Tomorrow at 2 p.m. Saudi time, we have another webinar that speaking regarding ultrasound guided PSNL, and Dr. Ahmed Zahrani will speak about the donor nephrectomy, lap donor nephrectomy, and also there's a talk about supine PSNL. So we'd love for all the audience to join us tomorrow as well, 2 p.m. in Riyadh time.
All the best for that. And you need a bigger platform now, guys. The 100 is not enough.
It's coming. 300 is coming for the next meeting. I will.
Take care, guys.
All the best. Thanks, everyone. Have a nice evening. Bye-bye.
Thank you. Bye.